Today we're going to talk about what is a cancer survivorship program in the first half, and then we'll talk about why we don't have many more of these that we need. So anytime I ask a question or talk about a program, I always think about what is the purpose and why we're doing, why do we need to do this? As Mr. Lucino said, for him it is personal. For me, it is personal. Because my father died of lung cancer when I was 15, within 5 months. He was the breadwinner, sole breadwinner of the house, and my brother and I are teenagers. So our family went through what a cancer diagnosis and treatment can do. I saw him wither away in front of my eyes. And that's my reason for bringing this to all my patients and families, that there is more than the cancer diagnosis. There is more to it, and we need to embrace that. So there are 16.9 million survivors in US in 2019. As National Cancer Institute said, it's a silver tsunami. And we're seeing more and more people who are about 65 years and older. And as a healthcare system, we're not fully prepared to handle this. I like this picture of the MassGov has on their website of all the dimensions of the wellness and what is involved with the cancer diagnosis and for the survivors. We heard from multiple speakers from this morning talking about the treatment side effects, whether it's a long-term or the late effects. Sometimes they happen during the treatment, and some of them, they happen afterwards, and sometimes they start after you finish the treatment. With the newer and newer treatments coming, immunotherapy, targeted therapy, chemotherapy, there are more we need to understand. With the immunotherapy, we're seeing more side effects afterwards, and they can happen after treatment. And not all of us are equipped to understand what these side effects are. And for example, with immunotherapy, it can affect your thyroid, it can affect the heart, it can affect the lung, it can affect any part of our body because it's our own immune system. So understanding all of these options, treatments, and understanding when we need to intervene, that is all we need to do and need to focus on. And there is also the premature and accelerated aging with all the treatments that the cancer survivors go through. And you heard about chemo brain, fog, all of these. So it affects the cognition. Just for an example, one of my patients came and told me, she's in her 70s undergoing treatment for her lung cancer. She said, I sat in the car for 5 minutes trying to figure out how to put this darn CD in the CD player of the car. Those are the things that we take it for granted. You don't have to think twice. But these are all the things that can change. And other ones like cardiac toxicity, depending on what kind of cancer drugs did you get, or if you got radiation to the chest area, it is close to the heart. So those are all the things that can cause, in the later life, it can cause hypertension, it can cause heart failure, or myocardial infarction, or like a cardiac symptoms, all of those. Sarcopenia, for example, another thing. Losing the muscle mass with all the treatments, and also lack of exercise because of the functional, you're not able to move around like before, whether it is from the tingling or numbness, or whether it is the neuropathy in your feet that it is affecting your balance, having falls from all those treatments. I also do see my prostate cancer patients and other GU cancers. For some reason, my male patients, they do not want to talk about their sexual function. I see that. it's a female to male, so that's I understand. But also sometimes you need to, as a physician, I need to take the time and ask them too. So there is part on my behalf. But also I'm encouraging all of you to talk with your physicians or advanced practitioners or your primary care physicians to talk about what is going on and what is affecting how your social life or your personal life is being affected with all of these treatments. Because unless you tell us, we wouldn't know. As you can see here, there are other aspects of emotional or psychosocial. Dr. Hall talked about the fear of recurrence, which is the most common, but also depression or anxiety. When someone lashes out or having anger, it is only tip of the iceberg. If you listen to them deeply and understand what's going on underneath, there is more than anger. It could be fear, it could be depression, it could be anxiety. But unless we dig deeper, we would not know. Other thing is how it is affecting their work life. If they have to cut down on the hours, and they're doing only part-time, of course it is going to affect them financially. These drugs and medications, they cost a lot. And there are a lot of co-pays, transportation, and taking time off from work. And if you have younger children, trying to juggle the balance between life and like their child care, all of those things, they take a toll on you. And questions like, what can I exercise? Scott there, who you're going to give a talk this afternoon from Yale, and Maura, sitting next to him, is our dietitian. So talking about, is my cancer, if I eat sugar, is it going to feed my cancer? Or having questions about what I can eat or what can I do? I had surgery. Can I exercise? Can I go back to walking? What can I do? And talking about smoking or alcohol consumption, as we talked in the prior ones before. So we also have to understand what are the other comorbidities, whether it is diabetes. With most of my chemotherapies, we give steroids, which can increase the blood sugars. But also, with the diabetes, can cause neuropathy. If I'm going to give some chemotherapy drugs that can cause more neuropathy, I have to be aware of it, and I have to work with our primary care physicians to control the diabetes and evaluate whether they're developing any neuropathy. And other one is the survivors of childhood cancers. They have also, they might have received radiation, and depending on the location of the radiation or what kind of treatments they received, it is also looking back into what is their history, what we can do, and what we need to do the surveillance. Lastly, caregivers. They are with the survivors in every step of the way. They take the burden along with the cancer survivors. It's not just one. It's the whole family and friends all around you. So this is what we need to talk about in the survivorship program. Institute of Medicine came up with this four-pronged approach of prevention, surveillance, intervention, and coordination. It is not only looking at the recurrent cancer, but also looking at the new primaries, the new cancer coming, and looking at what side effects they might have had and what they could develop in the future. So preventing all of this. And importantly, coordinating the care with the primary care physician and the other specialists to see what else can be done for a better quality of life for everyone. So this is our why for having a program of survivorship. Cancer does not stop when the treatment ends. We need to address the chronicity of cancer, and we have to expand the focus to include improving function, well-being, and recovery, treating everyone as a whole. That is why we need our survivorship programs. So keeping this in mind, we at Lahey started a survivorship program. I've been at Lahey for the last almost 5 years. So we started this program. We have 2 survivorship programs. One is run by the advanced practitioner, where they go over the treatment summary and the plan and look at what other things that needs to be done. But the second one is the multidisciplinary survivorship clinic, which I got it from my home institution of Yale, where I graduated from, thanks to my team. And we have a multidisciplinary survivorship clinic at Lahey now that has a nurse navigator who calls before and talks with the cancer survivors who are coming in and talking about what are their concerns and getting an idea. And before we go into the clinic, it's one-on-one. It's not a support group. It's for you. When you come in, you are it. And it's a one-on-one with a rehabilitation specialist, dietitian, behavioral oncologist, either with the MD or with a nurse practitioner. We talk about what are the things that we need to focus on, whether someone has neuropathy or whether it is affecting their walking or their quality of life, or if someone is losing weight, or if someone is gaining weight since starting the chemotherapy, or if they're not able to sleep, or having anxiety or depression or fear of recurrence. We talk about and we evaluate each and everyone one-on-one, and depending on their needs, we make a plan. Our rehabilitation specialists see how the functionality is, and then make referrals. If it is someone from head and neck, and if they're having swallowing difficulty, we make a referral to the speech pathologist. Or if someone got radiation to the pelvic area and having urinary incontinence or other issues, so we talk about, or with the lymphedema in clinic. So evaluating all of these and working with each and every one of them to improve the symptoms and also to make sure that you're leading a fuller life. Okay. We work with our partners, cardio-oncologists, to see if anyone is at risk for developing cardiac toxicity, or if they already have the risk factors, then how to minimize those. And we work with sexual function clinic, endocrinology, and more importantly, with our primary care physicians, to keeping them in the loop, and we're all on the same page. So now we know why we need the survivorship clinic. So let's talk about why are there not more of them. So if we all agree that this is much needed, then why can't we have more? Right? So there are some issues. So there are a lot of hurdles going into the survivorship and building a program. Even when I started building the survivorship program at Lahey, it was not an easy task. So we'll go through, but we got it done, and we're able to achieve that. But this is not easy. And again, the survivorship is not one size fits all, because everyone is different, and depending on what your needs are. As Dr. Nickel-Doe said this morning, talked about the side effects, but this is the research and the much needed research studies that she's doing with her team. And this is the information from her studies. So there are different models of care delivery for cancer survivors, whether it could be in the oncology clinic, or it could be outside of that specific disease group, or it could be at the primary care, or it could be a multidisciplinary clinic where the primary care and other specialists, the oncologist, and everyone works together. So there are pros and cons for each and every one of these. And being the oncologist, I'm standing here, I'll take the blame. I'm more focused on the cancer and making sure that the cancer is not coming back and making sure there are no other cancers that are coming. That's my focus. But from the primary care perspective, it is more of wellness, how you're doing, and making sure diabetes is under control, your blood pressure is under control, your heart failure is under control. So how to work with all of these and increase the functional capacity and make sure that you're leading a healthier life. So we both have like different perspectives, and with the, depending on where the clinic is, the focus could be different from the disease to the wellness too. When there is a multidisciplinary clinic or multi-specialty clinic, patients get from both sides, the information from both sides, both from the primary care and also from the oncologist. But sometimes the health organizations might think this might be an inefficient model, and the specialist or the primary care physician's time might be well spent seeing more new patients. So let's talk about the viewpoints from three different, from the provider, from the organization, and from the survivor or the caregiver viewpoints on the survivorship. So let's say from, as we talked, it could be who should take the lead, whether it should be the oncologist or the primary care physician, or it should be the MD or the nurse practitioner or the advanced practitioner. Who should be the one? And also it depends on the expertise too. I mean, as an oncologist, I might be maternalistic and I don't want to share my patients. So that is one thing that we oncologists sometimes face. And other thing is not having enough expertise, not having the education, what we need to do, okay, for the diabetes. I might be up to date with all the cancer treatments, but I might not be up to date with what diabetes treatments could be, or the high blood pressure, and what is the number that I should shoot for. And there is a knowledge gap. And sometimes we don't have enough resources. So these things, to build the programs, it takes people's time, efforts, and also sometimes financial too, depending on where you are and what kind of program you're planning to build. And sometimes it could be roles might not be clearly delineated. So from the organization and healthcare system-wise, it could be resource and time-intensive. They might be looking at the financial cost of it and trying to maximize the profitability and to survive in this healthcare environment. And also having the provider available too. And sometimes they might be thinking, oh, MD can see more new patients, and it might not be financially, it might not be more beneficial for the survival of the organization or the healthcare system. So let's talk about the survivor and the caregiver. So a few things when we started the program, the multidisciplinary program at Lahey, few things I heard is, it's again extra trip that I need to come in. I already am coming for the scans periodically. Why do I need to come for an extra trip? And again, it's taking time off from work. Why do I don't have the resources or financial resources to come, or the transportation. And this could be a new provider that I don't know, and this is new. It's not my primary care physician, or it's not my oncologist. What do we do? So that is the perspective I'm talking about from like what we heard. But let me ask you, what do you think? What is that, let's say if someone offers you survivorship program, what would be some of the things that come to your mind? You guys are very shy. Empathy. Bonding.
Ways of dealing with neuropathy.
Ways of dealing with neuropathy.
Consider time and location.
Time and location.
That's what I was going to say, because people have other things to do, and to get started with a new group always takes a little bit of extra effort.
So,
specific here, like support groups for just husbands or just wives, because those caregivers go through it in a much more different way than like a parent would.
so it's having a separate support group for each and every one, whether it's a husband or whether it's a wife or a parent or a child. So.
Being around other people that understand what you're going through, because talking to somebody else that hasn't been through it,
Yeah.
they don't understand.
It's connecting to the same tribe.
Online groups, is that common?
Online groups are common too on the Facebook or Twitter. There are like a lot of patient advocates. So Dr. Dijon in the back there and myself, we are very active on online, like the digital engagement in medicine and also in the clinical trials too. So there are a lot of patient advocates who are active online, and they're also depending on what kind of cancer it is. So there are a lot of online support groups that are available helping. For example, for lung cancer, there is a group called ROS1ers, which is one of the mutation, change in the DNA structure that specific. So there is a group. So there are multiple groups like each and every area of cancer. Go ahead.
I just wonder, are doctors receiving invitations to the Survivor Journey events, like the oncologists? Are they being informed of all these going on?
So that I have to ask Dr. Burton or Lisa. Or
Sure. We're encouraging folks to invite their physicians and their care providers all through all of us that are here today. I know that's something that Jay does as well. But I think a really great next step would be, I've done it for a patient in Barber with my practitioners as well. So that would be terrific if you could all spread the word.
But if they were sent materials and they could have something like what you presented
That's a
here,
great idea.
that what takes place here, so instead of us just inviting them, they would get it like oncologist to oncologist, and they'd have a little more information.
Absolutely.
About what to
It's a
expect.
good idea.
So they know if they're trying to do something, it's important. I mean, of course it is.
Right.
now, we also have Lahey, we're also doing a survivorship symposium September 21st only for patients and families. And the providers are also invited too. So it's open, it's free, so if anyone in that area. So.
Dana-Farber is also having a survivor reception on the 20th of June, I believe. So anyone that is a patient or has relation to Dana-Farber are invited to that as well.
Go ahead.
I would hope a survivorship program would include helping you to navigate through the health system. You know, the doctors that you're going to go to. So just as it was said this morning, to make your visit with whatever doctor you see to be more effective for you as a patient.
So it is having a navigator trying to walk you through the maze of the healthcare and the cancer care. Thank you. So what can we do? Okay. So we need to evaluate resources, what we have at hand, and see what we can do. And also identify who are the people that are interested in the survivorship, and evaluate what kind of clinics works for that organization, and visit other programs. That's what I did. I went back to Yale when I started this program, trying to build what they already, if they already are succeeding, take points from them. I don't have to start from scratch. I don't have to do all that hard work. They already did the hard work, so let me see what is working and not working, and go from there. And as Mr. Lucino said, philanthropy. We can do it. It starts from each and every one of us. We need to help each other. And we can start small and expand. The only way we can do, when Dr. Burton started, I'm sure he did not have all these resources. He was alone and with his wife, Susan. And that's how this whole thing started. So let's start with each and one of us and see what we can do from our standpoint and what we can do rather than waiting for someone else and coming and helping. Go talk with your doctors. Ask them, where is the survivorship program? What are the resources? If they don't know, educate them. I'm standing here, vulnerable, asking you what I can do. And you can do the same thing. You help us. You help us to help yourselves and help us to be a better physicians and better caregivers for you and for us. Thank you.